Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello and welcome from our newly expanded Axxess corporate offices here in Dallas. I'm Jennifer Gibson Osborne, here to share with you today another educational webinar titled Patient-Driven Diagnosis Coding. In today's webinar, you're going to learn and understand the role of ICD-10 CM coding under the PDGM payment system. We're going to learn some official guidance that impacts PDGM practice and policy, and then we'll learn the difference between groupable and non-groupable diagnoses. You might have also heard those called questionable encounter codes, or those that are allowed codes. And then finally, we're going to understand some simple practices to ensure compliance and accurate payment related to diagnosis coding in the PDGM payment system. Let's get started. First of all, why is coding important under the PDGM payment system? Well, for several reasons. We know that in order to be compliant with the OASIS guidance manual information, it tells us in that guidance manual that we need to comply with ICD-10's official guidelines and conventions when we're putting down codes in M1021 and 1023. The guidelines and conventions are basically the rules of applying codes, and they're much like the special rules that you have when you take advanced math. You know, if you've taken trigonometry or calculus, there are certain math rules that you have to know and commit to heart or memory so that you can apply those rules when you're doing those math equations. If not, you'll get an answer, but it won't be the right one. So that same similar kind of principle applies with diagnosis coding. There are certain rules, official guidelines and conventions, we call them, on how to apply and sequence codes, and if it's not done correctly, that can impact your payment plus your accuracy and can be a red flag to CMS, quite frankly. So that primary diagnosis in 1021, which flows over to the claim, is what's going to place that patient in the clinical grouper for PDGM. That's the only thing that puts them in a clinical grouper. So it's really important that we get that correct. And then the secondary diagnoses in 1023 that are placed over on the claim as secondary diagnoses, those may produce a comorbidity adjustment. So we want to make sure that we have specific codes according to the guidelines and conventions that will help us capture those diagnoses when appropriate. And the diagnoses finally are really what helps to paint the picture and give the reviewer data about that patient's needs and the patient's medical complexity. So let's talk a moment about ungroupable codes. You've called these, or heard these called, I should say, questionable encounter codes. And what these are certain codes, ICD-10 codes, that when are placed in the primary position, they will not compute a clinical grouper. The reason for that is that these particular codes that are excluded from the grouping model have either unspecified code titles. For example, it may say unspecified leg, and surely to goodness we can look and see what leg is affected if the patient has a disorder, or their symptom codes. And we're going to learn in just a moment why symptom codes are not a good thing in coding. Now, if you happen to place a diagnosis code in the primary position that is in this ungroupable code list or questionable encounter code list, as some have continued to call that, those claims will actually return to provider. They will not process because we are expected to update the code and put a more accurate, more specific code in its place. There are a total of 94,765 ICD-10 codes in the 2020 code set, and of those, only 43,287 qualify as groupable primary codes for PDGM. And of those 43,000 plus codes, only about 2.5% of those will calculate or add into scoring for the comorbidity adjustment. So why can't you use those codes, those ungroupable or QEC codes? Well, as we said before, it's because they're not specific enough. They don't give enough information about what's going on with that patient. For example, an unspecified anatomical site or symptom codes. And we're going to get into the symptom code guidance from the ICD-10 code set in just a moment. And again, as we just said, those claims will return to provider for a more specific diagnosis to be used. So let's look at some of the official coding guidelines and conventions, or the rules for coding. These particular rules will need to be followed under PDGM to ensure that we are not getting red flag audits and that our clinical grouper is accurate so that we are getting paid what we're supposed to be getting paid. This particular quote comes from the official guidelines for coding and reporting, section 2, when it talks about selecting that principal diagnosis. Again, that primary diagnosis or principal diagnosis is the one that's going to put the patient in the right group or clinically. And it tells us here codes for symptoms, signs, and ill-defined conditions from Chapter 18 are not to be used as a principal diagnosis when a related first listed diagnosis has been established. So basically what they're telling you with this rule is we should not use a symptom code when we have an underlying diagnosis that's already been established. So, for example, you wouldn't say edema if the patient has CHF. That's inherently related to CHF. We would code CHF instead, right? So we have seen in our industry a lot of use of R codes for gait abnormalities or weakness and things of that nature that are no longer going to be accepted because the guidelines tell us we should be coding the underlying disease process that's causing that symptom. And by that same token, we shouldn't be using unspecified codes when we can clearly find out the anatomical site of what's going on with this patient as well. All right, the next part we're going to see in official coding guidance says, list first the ICD-10 CM code for the diagnosis, condition, problem, or other reason for the encounter shown in the medical record to be chiefly responsible for the services provided. List additional codes that describe any coexisting conditions, and those additional codes go in the secondary spots in 1023 or on your claim in position number 2 through 25. This rule again comes from the official guidelines and conventions for the ICD-10 set, and you'll see the reference here on the page as to what section if you wanted to find it yourself. All right, so let's look at more coding guidelines. It tells us here in section 1B that codes that describe symptoms and signs as opposed to diagnoses are acceptable for reporting purposes when a related definitive diagnosis has not been established or confirmed by the provider. So there are instances where symptom codes are appropriate. However, they shouldn't be used in the primary spot. We need to be finding out what's going on with the patient. And there are still some kinks to be worked out in this particular payment system. But what we've noticed in the final rule is that CMS is telling us by the time that patient is admitted to home health services, the provider should have figured out what their problem is, not just a symptom, but what particularly is the issue, the underlying disease process. So there may be instances where symptom codes are appropriate in secondary positions, but they certainly shouldn't be in the primary position. All right, signs and symptoms that are associated routinely with the disease process should not be assigned as additional codes unless otherwise instructed by the classification. So we see not only are these symptom codes in Chapter R, or Chapter 18, I should say, the R codes, and of course there's signs and symptoms at the end of most every chapter in the code set. But what we're learning here is that we really shouldn't use those symptom codes if they're routinely associated with the disease process unless the code set tells you specifically to do so. Now, if you're not a coder, you may not know this, but there are some codes in the ICD-10 CM code set that have symptoms associated with them, like liver failure with ascites, for example. And then there are other diagnoses codes that do not have symptoms added to them. For example, diabetes with gastroparesis specifically is not a code. So there are some cases where you'd have to code a special manifestation of diabetes, and then you would list gastroparesis as well. But again, you shouldn't be doing that unless the code set tells you to do so. Okay? Additional signs and symptoms that may not be associated routinely with the disease process should be coded when present. So if it's not inherently related to the disease process, you can code the signs and symptoms. But again, we're talking about here secondary codes, additional codes. Those symptom codes are not designed by the code set to go before the underlying disease process. All right, codes for signs and symptoms may be reported in addition to a related definitive diagnosis when the sign or symptom is not routinely associated with that diagnosis, such as the various signs and symptoms associated with complex syndromes. The definitive diagnosis code should be sequenced before the symptom code. And this is just stated in a different way. This rule comes from the actual Chapter 18, Symptom Signs and Abnormal Clinical and Laboratory Findings Not Elsewhere Classified. So we see in the chapter guidance as well that it's telling us we shouldn't use those codes as primary. All right, so what is the clinical grouping impact? We've looked at some of the rules that apply here to coding. What's the difference? Well, depending on what clinical grouping the patient falls into, based on that primary diagnosis on the claim, the 30-day payment can go up anywhere from, depending on the classification, $943 for the MMTA surgical aftercare, up to, as you'll see, the highest paying grouper are the wounds at $1,567 group add-on just for the clinical grouping itself. This is not the total. This is what the primary diagnosis bucket calculates when you're looking at just the very basic calculation for the clinical grouping. So where does good coding begin? The answer to that quite easily is referral intake. We know from practice in prior years that trying to chase information down well after referral can be a difficult task. So your first line of defense is to get as much information as you can up front during referral intake, not only for beneficiary qualifications to receive the home health benefit, but also to make sure we have adequate information so that coding can be done timely and accurately. So some of the examples of the coding specificity that you might need: if the patient's being referred over for heart failure, don't take just plain heart failure. Ask them more questions. Is it systolic? Is it diastolic? Is it combined? What kind of heart failure do they have? We also have learned from the ICD-10 code set training and OASIS guidance that clinicians are unable to diagnose the origin of a wound. Now, once the physician or provider has told us the wound origin, is it a burn? Is it a venous stasis ulcer? Is it an arterial ulcer? Is it a diabetic ulcer? What's going on? Is it a trauma wound? Is it gangrene? What's going on? Once we know the origin and the underlying disease process, if we know that this is, for example, a pressure wound, then there are some things that clinicians can do, such as stage those pressure wounds. But the wound origin and underlying disease process must come from the provider. So you should never take a referral that just says open wound. That doesn't tell the coder anything. What type of wound is it? What happened to cause the wound? What is the provider saying about the origin and the disease process? And then find out if it's a complication, such as an infection or a dehiscence or an abscess or cellulitis, for example. And then once you have that information, you want to find out what disease process is causing symptoms that might be listed. For example, if you get a referral still with unsteady gait or weakness, you want to find out what's causing that gait abnormality. Rather than just take the weakness or the gait abnormality, ask the provider and the referral source, what is the underlying cause of that weakness or abnormality? Is it the COPD or CHF that causes their endurance to be so bad that they're just sitting around and becoming weak? Or what exactly is causing these symptoms? Now, we know that you're not certainly a robot and you're certainly not a computer. So hopefully you have some technology, your software solution specifically, that should assist you with those ungroupable diagnoses up front. So if you're able to put in what you have in your software solution and see that the codes that you were given are ungroupable up front, you can immediately turn around and contact that referral source again to let them know that you need to get a more specific code, that Medicare will not pay for home health using that particular code as primary. Now, this is not the same as pre-coding the claim. We're just saying you need to get as specific as information as you possibly can up front to begin your foundation of assessment and coding. You may still have to have clinicians in the home who are calling and querying the physician for more information, but you certainly want as much information as specific as possible up front. Let's look at the comorbidity adjustment now that we've talked about the primary. Now, those comorbid conditions are those diagnoses that are in the secondary position. And on the PDGM claim, those would be those diagnoses that are listed in position number 2 all the way through 25 if you have 25 full diagnoses. Now, there are certain diagnoses when CMS looks at that claim, they're going to scrub all the list of diagnoses you have, and those that are in secondary positions, if they fall into the comorbidity adjustment diagnosis list, you may have one of 3 different types of comorbidity. A 0 means there is no comorbid adjustment. A 1 in this case, in the column that you see number 1, that means that there is a low comorbidity adjustment. And then the 2 is a high comorbidity adjustment. Now, what you'll see is that each of the clinical groups, wound, neuro, MMTA, endocrine, and so on, each of those have their own threshold for that comorbidity adjustment as far as how much that adjustment's going to weigh. Now, that adjustment can add anywhere from, say, 14% up to 18%, but on average, it's about 17% of your 30-day payment. And what we know from that is that the comorbidity adjustment for a low will increase your payment about $95 every 30-day period. For a high comorbidity adjustment, you'll have payment increase about $275. And that has a slight variation from the clinical grouping to clinical grouping as we saw in the prior slide. As we've already stated here on the left, we know that the claim will be opened up. Currently under Home Health PPS, the claim only allows 6 total diagnoses on the claim itself. Under PDGM, that transparency is going to be opened up from 6 to 25 diagnoses on the claims. Now, if you're going to put a diagnosis down on your claim and on your plan of care, they certainly must be addressed on the care plan. That doesn't necessarily mean that you have to have an intervention and goal for each of those comorbid conditions, but certainly you need to have something on there to address them, even if it's just to assess for changes and notify the physician if anything changes in that patient's condition. You want to be a little more specific than that, but I'm just giving you general direction here. You want to make sure you're querying the referral source for additional information. Be prepared for probes, because we know with this increased transparency and with the change to a different payment system, anything that changes payment, we know that usually within, say, 6 months to a year, around that area of time, we begin to get probes to make sure we're being compliant. So be prepared for that. You want to make sure what you're doing is accurate. And make sure that you use only PDGM accepted codes as much as possible within those coding rules. Again, there are going to be some weird, strange instances from time to time where maybe PDGM and coding does not line up properly. And when that happens, we need to keep those examples and refer those back to CMS for further instruction. But certainly for the most part, you should be able to use those more specific codes and follow your coding guidelines. For the comorbidity adjustment, totally there are about 1,100 codes that will add monies in a comorbid adjustment grouper, which again is only about 2.5% of those 43,287 codes that are accepted as primary codes under PDGM. Remember, you can add a QEC or a non-groupable diagnosis code in a secondary position, but if you use a QEC in a secondary position, that particular code is not going to add any points toward or add any money towards your comorbidity adjustment payment. Now, the comorbidity codes are listed in certain diagnostic subgroupings. There are 13 subgroupings considered for a score of low, and there are 17 subgroupings considered for a score of high on the comorbidity adjustment. We're going to see some examples of those. So for your low comorbidity adjustment, there are 13 diagnosis categories, subcategories we call those. Only one diagnosis from those 13 categories will create a low comorbid adjustment. Multiple diagnoses don't automatically create additional adjustments. They have to fall in certain categories. So again, you're not a computer. You want to make sure that you have some assistance in identifying these comorbid conditions and what your scores would be and what your payment would be. You don't want to try to sit there and dig through 43,000 codes to figure that out every single time. Your software and maybe even a vendor-assisted coding company would help you with that. So let's look at some of the category examples. This is just a cross section of some of the diagnosis categories. You'll see, for example, cerebral 4 is one of the 13, circulatory 4 is one of the 13, circulatory 9, circulatory 10, heart 11, neoplasm 1, and you can see under the subtitles for each of those categories what kind of diseases we're talking about that would lend themselves to a low comorbidity adjustment. The other diagnosis categories are Neuro 5, Neuro 7, Neuro 10, Endocrine 2, Skin 1, Skin 3, and Skin 4, with just one little diagnosis example for each of those subcategories. Now, the high comorbid adjustment comes from taking 17 subgroupings of diagnoses and putting those into certain pairs. There are 17 subgroupings like the Neuro 3, whatever we just saw a minute ago, and those groupings are now paired into 31 different accepted pairings to reach this high comorbidity adjustment. A total of 1,107 diagnoses fall in high comorbidity pairings. And again, you're going to want some help keeping up with this because it's a lot to try and dig through manually. These are some sample pairings that came from the final rule, and you can see these are, I like to call these buddy codes or buddy pairings of the high comorbidity. They're like peas and carrots and, Forrest Gump and Jenny and cats and mice. They always are together. They can't work well or can't provide you this high comorbidity adjustment if they're not paired together. For example, here you've got a circulatory 4, hypertension with chronic kidney disease, paired with a skin 1, which is like a cellulitis or lymphangitis or pressure ulcers. If you have both of those diagnoses somewhere in positions 2 through 25 and they're in pairs, and doesn't mean they have to be sequenced together, but you have to have both of those somewhere in that secondary diagnosis coding, then that's going to put the patient in a high comorbidity adjustment. So let's analyze what we've learned so far using a scenario, and then we're going to plug it into the PDGM grouper and see what we're looking at here. So your patient's a 75-year-old male who was stung by a hornet about 2 weeks ago, and he originally presented in the ER with cellulitis of the right lower extremity. He was admitted to the hospital for IV therapy, and symptoms progressed while he was there at the hospital, and patient was diagnosed with possible MRSA sepsis and developed gangrene of the right great, second, and third toes. He's being discharged home with IV antibiotics for 6 weeks by PICC line, wound care to the toes that were debrided 2 days ago. PT is also ordered for balance and gait training due to neuropathy, weakness, and lumbar spinal stenosis with claudication. The patient has diabetes and takes insulin daily and as needed per sliding scale. He also has coronary artery disease. He has a history of a motorcycle accident 15 years ago with shortening of the left leg due to displaced segmental fracture of the tibia fibula. His spouse is a CNA and is expected to learn how to give the IV antibiotics after training by the home health RN. The RN will then change the PICC line dressing every 3 days and PRN dislodgement. Now, after the 3rd day the patient is at home, the physician states that patient now has sepsis and he wants to add telemonitoring. Okay, so we're looking at coding this particular case. There's some key components of coding that if you're not a certified coder, you may not pick up on. So let's talk about those. For example, when we admitted this patient, the patient has cellulitis. And there's a coding convention that tells us if the patient has sepsis but it develops after admission, then you don't code the sepsis first. Okay, and that can be very confusing because when you look at coding and you think systemic, the foundational rule or part of the rules is that you code the systemic and then you code the localized. But then there's another rule that says you code whichever is the reason for the encounter first. So if they presented with cellulitis first and it developed into sepsis while they're on home health, then you code sepsis. Now, and I know that's confusing. I want to go back for a little bit, and we have to really pay attention to how this is worded. the patient was diagnosed with possible MRSA before he left the hospital, we know in outpatient coding, we can't use possible as a true diagnosis. So we wouldn't code the sepsis, except for 3 days later, the physician comes back and says, oh yeah, now he's definitely progressed to sepsis. So he didn't have it at the time of discharge. At the time of discharge and admission to home health, he had cellulitis, and then he developed sepsis for sure 3 days into our home health episode. So for that reason, those reasons, we've coded cellulitis first, L03.115. That puts the patient in a wound grouper, and we see that it's a skin 1 for the comorbidity adjustment. Our second code here would be A41.02, sepsis due to MRSA. That would fall under the MMTA infection clinical grouper. E11.52 is the next code. That's type 2 diabetes with peripheral angiopathy with gangrene. That would also fall into the clinical grouper, and you see it's an endocrine 3 for comorbidity adjustment. Then we're coding the toxic effect of the hornet venom accidental initial encounter. That's what caused all this. It's still going on as the underlying reason. We put an A at the end of that, and it's MMTA other. Next, we have long-term use of antibiotics, Z79.2, and guess what? It's not in the clinical grouper at all. So it's one of those QECs. If we put that primary, this would return to the provider to add the correct code. Now, it's not in the clinical grouper, but it also doesn't add anything to the comorbidity adjustment either. But it is an appropriate code, so we're going to put it down in the secondary. Then we have an encounter for adjustment of vascular device. It's a complex nursing in that case, Z45.2, and it neither has a comorbidity adjustment. Then we're going to get into those other underlying problems, because we saw in the scenario, and I'm going to back up and let you see it, that he's also ordered PT for balance and gait training due to neuropathy, weakness, and lumbar spinal stenosis. And then we also saw that he's got this leg shortening from this old motorcycle accident 15 years ago. So those codes certainly help explain why the patient's having abnormality of gait and weakness and so on. In those cases, we code the underlying reasons for the gait problems and weakness and not the actual symptom codes. So you'll notice we don't have a single abnormality of gait or weakness listed at all. But what we do have is the diabetes with angiopathy. We have the lumbar spinal stenosis with claudication. We have the unequal limb length acquired, left tibia and fibula. And then we have the displaced fracture sequela, because that fracture has healed with some problems, which were those unequal limb lengths, okay? So all of those are sequenced according to guidelines, and those all fall in the musculoskeletal rehab grouper, and the spinal stenosis adds a comorbidity adjustment category of musculoskeletal 4. Now, we also see at the end E11.42, diabetes with polyneuropathy, which again explains parts of the reason for the abnormality of gait. And we know with diabetes coding that we have to add as many codes as needed to explain all the different manifestations of diabetes, which is why we have more than one diabetes code here. I-25.10, atherosclerotic coronary artery disease without angina. That would fall in the MMTA cardiac if it were primary in the clinical grouper, and it's a comorbidity heart 12. Now, I ran out of room on the slide here, but you would also add long-term use of insulin down at the bottom there as a code. Now, some of us, maybe if you're not a coder, you may be wondering, well, how did she know it's type 2? He's on insulin. Well, there's actually some guidelines and conventions in the code set that tell us if the physician does not state what type of diabetes the patient has, even if he uses insulin, the default of the code set is type 2. So although our scenario here did not specifically say type 2 diabetes, we can assume, not us assuming, the code set itself assumes with its official rules that it's type 2 unless the physician states otherwise. Now, if you wanted to query, you certainly could, but because the code set makes that assumption, we don't have to. All right, let's keep moving. So we're going to plug this patient into our PDGM resources here. In this case, it's the Axxess Home Health software. We're going to put this in as admission source and timing. We know that it's institutional early. We got the referral from the hospital, so the patient was in the hospital 14 days prior to the home health admission. That's what makes him institutional. This is also the first 30-day payment period, so this is an early episode for admission source and timing. The clinical grouping, when I put in my L03.115 cellulitis of right lower limb, we see that the wounds category is the correct category. And just by the way, the sequencing of the cellulitis versus the sepsis, depending on what's going on with that patient, that could be more than $400 difference per 30-day period. Now, if that particular code, how do I say this nicely? You don't want to switch the codes around just because cellulitis means more money. I can't be clear enough on that. If you do that kind of stuff, we call that gaming the system. Medicare calls that fraud. You don't want to code based on the dollars. You code based on the conventions and guidelines and the focus of care for the patient. In this case, the guidelines told us the reason for the encounter, which was cellulitis to begin with when he came to home health, that's what you code primary. And then we have other guidelines and conventions that say if sepsis developed while he was on services, that goes secondary. Had the physician in this particular scenario said from the beginning, patient has sepsis, at discharge, sepsis should have gone first. And that one change in the grouper, the way it's set up currently, would mean that I would receive actually $400 or more less per 30 days because the MMTA infectious disease pays less than wounds does. Does that make sense? It's kind of tricky, and that's one of those caveats where, I said there's some wrinkles and some fine-tuning that needs to be looked at as far as the coding, but that's the way the system is set up currently. Again, so we did cellulitis because that was what was going on. That's what was confirmed at the time of admission. And then 3 days later, the physician comes back and says he has now developed sepsis for sure. Now we're going to look at our comorbidity adjustment from the secondary diagnoses on the claim. So we see here that the first secondary listed diagnosis is the sepsis, and it goes all the way down through the atherosclerotic heart disease of native coronary arteries, I-25.10. Again, I ran out of room on the slide to add the insulin, long-term use of insulin code here, but it wouldn't have changed anything here. We see that we have a low comorbidity adjustment. Now, you might have thought, if we back up a slide or two, you might have thought, having looked at the comorbidity adjustment column over here, we have more than one comorbidity adjustment category. However, we don't have any of these that are in pairings. And remember the difference between low and high. Any one of these puts us in the low category because we've got one of the different categories here that puts us into a low comorbidity adjustment. However, just because we have more than one, that doesn't mean automatically it goes into a high comorbidity because there are none of these in the 17 different paired groupings for the high comorbidity adjustment. So for that reason, you saw it was low. Now let's look at our HIPS score and our payment projections. We did our OASIS and completed it in the system, and we saw that the functional impairment level is medium from our OASIS data. And so now we're able to look at our home health resource grouping, our HERG score, which is institutional early. We got the cellulitis primary. It's a wound category, medium functional. We've got a couple secondaries here, and we see it's a low comorbidity adjustment. For the first 30 days, we see our case mix weight is 1.614 with a HIPS of 2 CB21, and we are now able to see with all that information what the LUPA threshold is. For this particular first 30-day period, the LUPA threshold is 5, which means if I get 5 visits or more, my potential income is about $2,800. Let's look at the second 30 days. The case mix weight drops to 1.0279. My HIPS changes to 3 CB21, and my LUPA threshold changes from 5 to 3. So the LUPA threshold is different for each particular home health resource group, okay? So for the second 30 days, if I do 3 or more visits, my potential income is $1,783. Now, one little caveat that is also new to PDGM because of the billing periods has to do with coding changes. Now, in PDGM, the coding on the claim is what they're going to use for your payment calculation. They're not using the OASIS and the iKeys database anymore. Currently, under Home Health PPS, we are told that the OASIS, the plan of care, and the claim have to match. Under PDGM, that's changed. Now, normally, the first 30-day period, the OASIS, the plan of care, and the claim will match, normally. But under PDGM, that second 30-day period's OASIS, plan of care, and claim doesn't have to match. For example, if you do a SCIC, a significant change in condition or other follow-up, or you do a resumption of care, those OASIS can change that primary diagnosis. And depending on where they fall in those 30-day periods, that diagnosis would need to be updated on your claim for the second 30-day period. We also know that resolved diagnoses, according to the official guidelines and conventions and the OASIS guidance, says we have to follow that. Resolved diagnoses should be removed from the diagnosis list whether you have an OASIS or not. So even in the absence of a SCIC or other follow-up, or in the absence of a resumption of care, if the first 30-day period, for example, you were seeing that patient for pneumonia, and that pneumonia resolved, and the patient also had CHF, and the buildup of that fluid from the CHF is what caused the pneumonia. Whenever we're looking at the second 30-day period's final claim billing, it may be that that pneumonia needs to fall off because it's resolved, and CHF needs to be bumped up to primary diagnosis for the second 30-day period. And when that happens, your OASIS, your plan of care, and your claim won't match because those are not unanticipated changes. We anticipated that the pneumonia would resolve, and it did. And because of that reason, it's now resolved in the second 30-day period. We don't need that on our claim. So for those reasons, we're going to have to think about those coding changes and our processes and how we're going to correct that claim for the second 30-day period. Now, let's think about some OASIS timelines when we're talking about that as well. Remember, your resumption of care must be completed within 48 hours of patient discharge, or you didn't know the patient was in the hospital and you didn't know they'd come out until the aid goes. In that case, within 48 hours of agency knowledge of the return home. Your significant change in condition is also to be completed within 48 hours of knowledge of that significant change. So you should have a policy in place. And by the way, the SCIC came about again in 2018 with the updates to the conditions of participation, although it never really went away, but it resurfaced blatantly with the COPs. For that reason, you should have in place a policy regarding your SCIC completion. Now, that SCIC significant change in condition definition is that the patient has an unanticipated increase or decrease in function, or an increase or decrease in their abilities, or they have a new diagnosis that was not anticipated, a significant change that was unanticipated, whether it be a good change or bad change. And so your policy should be something that dictates when and who they are, if your clinicians in the field pick up on something, who do they notify to see whether or not this needs to be a SCIC, and when are you going to do the other follow-up OASIS, and so on. Your policy is what will dictate that for you. Resolved conditions, as we said just a little while ago, according to the official guidelines and conventions, resolved conditions should not be coded. If a condition that was primary resolved in the first 30-day period, it should not be reported on the claim for the second 30-day period. The agency needs processes and policies on changing the diagnosis in the second 30-day claim when no OASIS is associated. And we talked about that, admitted for pneumonia, which resolved on day 22. Your new focus for the second 30-day period is chronic heart failure. And I've got asterisks there because that's just to show you, if it's at all possible, get them more specific. Is it chronic systolic? Is it chronic diastolic? Is it acute on chronic? What kind of heart failure are we looking at? That's the code you want to use because it's more specific. And you would do that when there's no resumption of care or SCIC, but your change in focus has happened for the second 30-day billing period. All right, so let's avoid some common mistakes. Some of the things that get us in trouble in home health and will certainly be looked at under PDGM, you want to make sure your ICD-10 coding is accurate. Now, you may not have an HCSD certified person in your office doing coding now. My advice to you would be first steps, analyze the accuracy of that person's coding. You want your coding accuracy to be at least in the 95% range. You don't want to have someone coding and they're only doing 75% accurately. So have someone who is certified to come in and look at your accuracy. You also want to look at the OASIS accuracy. Are you completing the significant change in condition appropriately and according to your policies and processes? Do you know when you should do one? Are you getting those OASIS locked timely, and are they exported before you get your final claim bill, for example? You want to make sure that your episode management, we didn't get into that specifically here, but we did see that each of those 30-day periods have their own LUPA thresholds. So LUPA management's going to be a really big deal. We're going to see that in a subsequent slide or webinar, but let's say that your LUPA threshold is 5 and the 5th visit is scheduled on the last week of the 30-day period, and that 30-day period may end on a Wednesday, and maybe you have a visit scheduled on Tuesday, and that Tuesday visit is the 5th visit, which meets your LUPA threshold to give you full payment. And if I'm the nurse out in the field and I don't realize that, and I decide I don't want to go on Tuesday, I'd rather go on Thursday because I picked up another patient, and I move that visit, then I just created a LUPA, which is going to be about $1,500 less pay on average. I don't want to be the one that cost that agency $1,500, $2,500 just because I moved a visit. So you need to have a way to look at your scheduling in 30-day periods and manage your LUPAs. And of course, Axxess's home health platform takes care of that for you. Make sure you look at the unique skills of the interdisciplinary team and that you have the right persons doing the right things for the patient. You certainly don't want to eat up all of your revenue with overutilization. For example, you might want to have the aide meet the physical therapist out at the home and have the physical therapist do the aide plan of care to include passive range of motion and or walking the patient every visit. Why shouldn't each discipline walk that patient if they're having problems with gait abnormality or endurance and balance issues? If it is safe, certainly every discipline can be getting that patient up and moving them, not just the therapist. And that's good for money management. It's also, and more importantly, important for your outcomes. And then we also have to think about supply management when we're thinking about our episode management here. So we need to code properly, but we need to have the right things in place to make sure that we manage the monies that we have in each of these 30-day periods. And of course, you're going to want to look at productivity standards for your coder and for your visiting clinicians. Make sure you use that technology to assist you. On referral intake, your technology should be able to identify those codes and whether or not they're groupable as a primary diagnosis versus their questionable encounter codes and so on. You're going to want to have a payment calculator included like we saw a few slides back so that once my OASIS is locked, everything is completed, I can figure out using the grouper software in the agency core or the home health software here at Axxess, we can go ahead and figure out what our anticipated payment, our HIPS and HERG score and so on would be and begin to manage that episode. Orders management is another huge deal under PDGM. We know that final billing, having to do that twice in a 60-day period, that's going to impact our cash flow. And so we need to make sure that our orders are written timely, that they're sent timely, they're followed up, and that we get those orders back in time, that we can bill that final bill soon after the 30th day has commenced. Because of that possible change in focus that happens for the second 30-day period and the changing of that coding that would not be related to an OASIS and the pneumonia example that we talked about, You might want to think about having a 30-day conference to see if that patient's change of or care is going to change focus so that you can relay that information to your biller. In the home health software here at Axxess, we've thought about that and we've added a change of focus form so that when you have those conferences or those conversations, you can go ahead and fill out this form, which will then flow over to your claim with the updated coding and sequencing. So how will your software flow that information? If you're not an Axxess user, how is your system going to do that for you? And especially when there's no OASIS associated, is it going to update for you and make sure that your claims are accurate? Because what you don't want, as we talked about earlier, with this change of payment, we know probes and ADRs are coming at some point in the future. What we certainly don't want is to have a 30-day payment period where we didn't update the coding. It still says pneumonia. Pneumonia is never mentioned in that 30-day period. All we're doing is teaching CHF, CHF, CHF. Then that could open us up to paying back monies or having a payment adjustment or even a denial. So we want to make sure that what we're doing is accurate and use your technology to help you. Thank you again for joining us here at Axxess today, and we hope that you'll join us again for another webinar soon.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on software advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.